There's a long line, so maybe we'll open it up to Q&A.
Thank you. Stella Bielas from UCSF. Thank you very much for this excellent panel. And I would just want to congratulate Ambassador Castilla for all the efforts that Peru is doing. I think they're starting a tremendous policy on diet and food, learning from the lessons from tobacco control, and is one of the few countries that is actually applying some of the policy lessons related to tobacco control into some other risk factors, and that's wonderful. I want to follow up a bit on Loyce said about the Sustainable Development Goals. And I think you're right, and we talked a bit about that yesterday, that is tremendous opportunity for integrating in the whole development agenda the issue, not just cancer, but NCDs, and we may need to just lump together to get a stronger, like you said, less fractured voice. But I think we are still way too timid. And I think, for example, we haven't really heard, we have heard a lot of whining, but no outrage. You know, so for example, you know, I would love to see, for example, the government of Peru or some other countries go back to 8 agencies and say, this is wonderful, but we want to include NCD preventions in the aid package. You know, it has to come from people that would have, not from me. I can scream all I want. Nobody will pay any attention. I'm not even in DC to begin with. The other thing is that we are, our gracious hosts have a lot of influence. And I haven't seen a previous IOM, and now is Academy, National Academy of Medicine, and I haven't seen an open letter to development agents saying this is where the funding needs to go. I mean, we have the data. Yesterday, it was very clear to us. And why don't we have a letter that comes in the Washington Post saying the funding is misguided or needs to be reemphasized? And the letter could be signed by the National Academy of Medicine, by the American Cancer Society, by the American Heart Association, by all you important people there. And so I think that will get somebody to pay attention because it carries weight and it brings a unified voice. It can't be, oh, let's just do cervical cancer or breast cancer or diet. It's all together. The preterm birth initiative, $100 million. Preterm birth initiative. Does anybody here knows how much smoking cessation from pregnant women is included in the $100 million? Or how much prevention of exposure to secondhand smoke? 2 of the biggest preventable risk factors are preterm birth. Very cheap, by the way, very cost effective. And where is the outrage? There's a $100 million global initiative and things that we know. So I think not just we need to be more effective, I think we need to be a little louder, but find our assets. Who people listen to? The National Cancer Institute, they might have a little problem signing up an open letter. I get that, but others don't. So let's find out the ambassadors of different nations who are affected or could benefit. So it's just an idea out there. Thank you.
The thing is that when the SDGs were discussed on parallel, there was this whole discussion on financing that came, because meeting the SDGs is going to be very costly. It's not only the 100,000 billion fund for climate change as an example, but there's, you know, all of these things are going to be very costly. And actually, as a matter of fact, Peru hosted a couple weeks ago the IMF and World Bank meetings. First time in 50 years it goes to Latin America. And there was a big discussion among the important people, the really important people, you know, the treasury secretaries of the world and the finance people. And they put actually a policy that the U.S. government is actually promoting. Peru is part of it. It's based on the OECD, to try to reduce tax evasion and aggressive tax planning that would unleash lots of resources that now are being, you know, not used appropriately to fund some of these things. So definitely, if you don't really put the American thing, that you're money where your mouth is. Exactly. This is all a wish list of good intentions. This is going to be very costly. And a country now that seems to be doing better has to rely less on ODA, on official development assistance, and its own resources. So all of this money that we put together is our own budgetary, it's our own taxpayers putting in money and having a policy, having a government prioritize what's important. And for us, human capital, and within this, health, is critical. So this is our own experience. But really, this is an issue that goes really beyond just chipping in, you know, is it really a huge issue so that the 2030 is met with a slight success?
I think there's a bit of an elephant in the room here because I hear you and I agree more than you know. I will go off on a limb and try to speak for maybe government folks who can't speak to this, but Tom mentioned yesterday also the importance of agents, U.S. staff, actually, from USAID and other agencies really speaking to this. There's a bit of, from what I've heard, there's some fear that, you know, if they talk about the importance of this, sort of robbing Peter to pay Paul, another great American expression. But there's a fear that they won't be able to do some other things if they ask for money in one area. I mean, Congress will tell you the pie is only so big. I think countries face this fear as well. If we go and demand money for cancer and other non-communicable diseases, does that mean we get less for HIV and some of these other diseases that are still a problem for us? So that's just, it doesn't mean we don't sort of, you know, again, show outrage, but I think that that's also what a lot of these champions we're hoping speak out more are up against.
Turn to this side.
So talking about money and finances, I'm really interested to know from the ambassador, since you clearly have thought, or the government thought about the issue, what is the current cost of cancer vis-a-vis budget or health budget? And what is it that the government is intended to invest or has been investing to shift that thought from advanced disease to potentially early detection or prevention? And when are you thinking that return on investment, or when did the government think that the return on investment will start happening?
I'm ambassador, so I forgot.
Oh, you can't get out of that. You are the finance minister.
Not the numbers guy anymore.
No, I think there's been a budget allocation change. For instance, just to give you broad ideas, usually 50% of our budget, taking away pensions, is dedicated to social sectors, within which you have education and health really is almost 80% of such budget allocation. And I would say it's about 2/3 education and 1/3 health. So still there is room, you know, for the budget allocation to increase for universal coverage, for instance, or for tackling, you know, catastrophic diseases such as cancer or other diseases. Now, this is obviously still very insufficient, quite insufficient to really cover things. That's why we try to, once again, and I think I'm reiterating the fact that we won't be able to cover fully, you know, all incidences, the full cost, but we can really do a strong effort towards prevention. So, and early detection, and the specific cancers, which, as you mentioned, are the low-hanging fruits, you know, which is like cervical cancer. That's what we thought that we have the highest return. Lung cancer, stomach, breast. Those are the ones that are easier, and I don't want to use the word easier, but they're the ones that we have higher probability of being successful in treatment, vis-a-vis other, you know, cancers that are more complicated and more costly. So this is something that actually we need to actually think that the linkages that when we allocate budgets, is we're not only allocating to health. Health is very much intertwined with education. You know, more educated people tend to, you know, go and seek better health advice. In terms of sanitary conditions, water, sewage, So we need to look at the whole package, you know, and it's wrong just to look at one slice of the pie. You need to look at the whole other areas that may be related to the effectiveness of such cancer. So we just began, actually. 5 years into or 6 years into a prevention plan is not enough. We need to have really a generation really to find results. That's about our own experience. And I think this actually will transcend, it's already 2 governments that have pursued this policy. And we hope that next one that comes along and next few ones will keep on doing this. And I think health is now has a higher importance, I think, in the policymaker ladder. The discussion you guys had here in this country actually was a bit puzzling and a bit illuminating for some of us down south about the healthcare issue and the coverage, and it really made us realize that we were doing the right thing. Not very diplomatic, but sorry. But
How are we going to get out of that one?
It is true. I better.
We're here.
Hi, good morning. I'm Paul Holmes with the American Cancer Society. And when I first got in line today, I thought I was going to have something new and original to talk about. Since then, the panelists covered this, and Stella really hammered it. So if you forgive me, I'm just going to jump on the bandwagon. And that's this session is particularly about engaging stakeholders. We've heard over and over over the course of the last couple of days about the great things that we are accomplishing. The need has been clear, infinitely clear to everyone in the room. And yet, if we look at what the stakeholders are implicitly telling us, they are implicitly telling us that what we all care so much about is not a high priority to them. If we look at the, yes, we do have the SDGs, but we still have a situation where cancer and other non-communicable diseases are tremendously underappreciated and certainly under-resourced. Cancers alone kill twice as many people every year as do HIV, TB, and malaria combined, and yet they receive but a minuscule fraction of those resources. I think that the people who are engaged in global health really do care about patients. They really do care about who dies and who is disabled. At the same time, they are sort of put in a box. They're told that they have to spend their money on X, Y, or Z, and we have not done an effective enough job convincing folks that cancers and other non-communicable diseases really matter, and that what we care about really matters to people who work on HIV, really matters to people who work on TB and maternal and child health programs. So, I mean, it's one of the things that's been interesting to me the last couple of days is how many of us are here just focusing on cancers, and we have not brought in other absolutely key stakeholders into this conversation. So I would challenge myself, the American Cancer Society, and all the other stakeholders in this room to really think about how we can engage USAID, engage DFID, engage the World Bank, engage Gates and other organizations more effectively in this conversation so that we're not seen as competitors, but complementary to the work that they are doing.
Thank you.
Thank you.
I don't think, oh, yeah.
Okay. Thank you. Yul Dorothea from the Southeast Asia Tobacco Control Alliance. Maybe a little addition to the discussion on the SDG. So the ambassador talked about how costly it would be, but I'd rather frame it as actually being, this is an acronym, a cheap solution, considering that the SDGs talk about the climate, health, and environment, so that's the CHE, in all policies. So WHO has pushed health in all policies, but now we're talking about climate, health, and environment, which all actually affect health at the, in the long term. So we're talking about prevention of disease, of cancer very specifically. But I think if we think about trying to find resources for all of this, I again talk about tobacco taxation. The ambassador talked about trying to find domestic resources, and taxes are really the only domestic resource. And it makes sense to tax tobacco. I don't know how many are aware of the Thai Health Promotion Foundation, for example, which is based, funded by law from just a 2% surcharge on tobacco and alcohol. And that's actually generated for them currently $120 million per year to fund prevention primarily, plus also community programs. And that's been very effective. In the Philippines, I talked about universal health care being funded by tobacco taxes that now covers 70% of the population, including catastrophic diseases like cancer. And we know it's effective because the tobacco industry has actually started to attack these sources of funding. For example, in Thailand, after close to 15 years of success, the industry is now saying, why should we pay this 2%? Because it adds to the burden on the industry. In Vietnam, they opposed setting up a similar mechanism for sustainable funding for tobacco control. So at the same time that we're looking at trying to reduce consumption, they're also looking at trying to reduce the revenues that governments could use for health. And the other comment I wanted to make was with regard to the impact of the US on the rest of the world. I don't know how many are aware that the Indonesian president is in the US to speak with Obama. And within his stay in the US, Philip Morris has set up a meeting with him to talk about a $2 billion investment in Indonesia. So while it's across the Pacific, I think there could be a lot more done from the US end to prevent the epidemic spreading outside of the US. The low-hanging fruit that was talked about, one of them is just graphic warnings. So there's been a difficulty getting it in the US, but I think if the US actually had graphic warnings, it would easily help us in the other parts of the world get graphic warnings in all other countries. So at the moment, there are about 80 countries that have graphic warnings. But if the US got graphic warnings, you know, within the next few years, there would be no argument from the tobacco industry to say we can't do it in all countries. So just a little encouragement to our US colleagues. If you could get graphic warnings in place, they're cheap. You don't have to spend for them, and they're very much cost effective. So thank you.
Thank you. Any particular comments? Yeah.
Actually, I'm going to now talk as an economist more than an ambassador. Because usually the easy thing is to tax it, and then it would be so expensive. But this is a thought that usually is designed for a country that has enforcement, that has, you know, no contraband, no smuggling. So we had long discussions with our healthcare people, and they say you have to increase the taxes. We have excise taxes to discourage, obviously, the consumption of cigarettes. But they told me, no, you have to triple the tax rate for this. And I said, yes, up to a point, because then it becomes easier for individuals to really smuggle, you know, cigarettes from neighboring countries. So it's a trade-off. Perhaps this would apply better for countries that have, you know, very, you know, there's law enforcement, you know, your borders are under control. But for many countries in the world, Peru included, our borders are very porous, and there's a lot of contraband going on. And if you were to increase tremendously the price of cigarettes through taxes to discourage its consumption, you will have an entry of informal, illegal cigarettes. So it is a trade-off that you need to adjust in terms of the law enforcement capabilities of a country to tackle this issue. Just as a
So we're coming towards the end of the panel, and I wanted to provide an opportunity for our panelists to give maybe brief 1-minute closing remarks. We've talked about a lot of different issues: health system strengthening, thinking more broadly, planetary health, public-public partnerships. So maybe we can end with some 1 minute each on how different stakeholders can be engaged.
Well, I just wanted to speak to the policy interventions. You know, we hear a lot from the tobacco world about policy interventions that can really make an impact. I still have yet to hear some of the policy interventions for cancer screening or other cancer prevention aspects. So learning from non-communicable diseases, for example, the tax for soda, for example, can have an enormous impact. Is there some way that we can think in terms of other evidence-based interventions that speak to policy and maybe low-hanging fruit and less costly?
Well, first, I would like to reiterate what I said earlier, that we really want to work with the partners in this room and elsewhere to see if we can unleash the CDC and USAID on cancer and NCDs, because we definitely know we need them at the table. Secondly, I just want to emphasize the importance of working together, and as Paul mentioned, beyond just cancer on NCDs. It's something we're trying to encourage our cancer centers to do. It's something we're trying to work with partners in the various regions where we're organizing Cancer Control Leadership Forum, to think about tobacco, to think about surgery, to think about all the related issues that are help strengthen health systems to address cancer and other issues.
I guess I would end by reiterating my plea that we be orthodox to the science, try to be rational, and figure out the things that work and try to push them, and the things that don't work and try not to push them, to prioritize things according to what's going to have the greatest impact, and to work together. I guess cancer is a very emotional issue, and we do need to be emotional about it and develop a fire in the belly to actually attack it. But we also need to be rational in our approach, or else we will fail. Thank you.
I think reiterating, this is something that is fundamental, and it's something that really can touch the life of anyone. You know, it doesn't really discriminate. You know, in any sense. You know, it can touch any person, any household. So for this, in a low resource area, you know, you need to prioritize. You need to prevent. Those are the things that usually, and one needs to really educate a lot about this, and get informed citizens, and work with partners. Now, our work with the U.S. and in particular with the NCI in education and research, to try to you know, have know-how transfer and work towards capacity building, is something essential that we're trying to push. But this is something that will see results, you know, a generation from now.
Our former CEO, Doug Goldman, would say to the staff often, now is the time. And it's something I come back to, especially now. You know, we're seeing a shift right now in this space. We're thinking differently about what global means, you know. It's less them and more we. We're thinking differently about what health entails and what it includes. We're thinking differently even about resources and being, you know, thinking more creatively about, you know, beyond the financing. And so I would encourage all of us as a takeaway to really take advantage of this shift, because now really is the time for us to find our space in this area and really create change. And don't forget the patients and the people at the center of all of this. That's why we're all here. Thanks.
So I said these were closing remarks, but we have one more question, 1 more minute. Or do we want to take it? No.
No, because you guys made your closing remark. I guess, well, actually, I'll say something.
Actually, no.
Gwen Darian from Cancer Support Community, never pass up the opportunity to have the last word. I just wanted to, I had so many things to say, but I just wanted to build on what Otis had said, which is thinking about approaching these things rationally. So I think that one of the most important takeaways from these past 2 days is to really think about partners in rationality that may come out, that may not be the people that we automatically think of as our partners. And disease advocacy is fundamentally interest group politics, whether it's from a patient advocacy point of view, whether it's from a physician point of view, whether it's for something else. And I think that if we really look beyond who are in our comfort levels, in our silos, we will achieve a lot more. And as a longtime patient advocate and running many programs for advocates, my operating principle was always that I would work with anybody who would work with other people. And that meant that about 75% of the advocacy groups I would work with. But I think we should look beyond this in terms of looking at this global care and look at partners, look at expanding the stakeholder group. So there are lots of potential partners in rationality. So
Thank you for that. So the time is now. Thank you to our panelists. I'll turn it over for wrap up.